This is Dr. Marty Peterson. I'm the Outreach Coordinator for the Antimicrobial Stewardship Project created by the Center for Infectious Disease Research and Policy at the University of Minnesota. It's my pleasure to welcome our participants to today's webinar, Pediatric Antimicrobial Stewardship, presented by Dr. Jason Newland, who's an international expert physician in pediatric infectious diseases. Before we begin, a little bit of background about Dr. Newland. He's the director of the Antimicrobial Stewardship Program at St. Louis Children's Hospital and associate professor of pediatrics at Washington University in St. Louis. From 2006 to 2015, he was on the Pediatric Infectious Diseases faculty at Children's Mercy Hospitals and Clinics in Kansas City, Missouri, where he developed and served as medical director for the Antimicrobial Stewardship Program. He also served as the inaugural medical director of patient safety and systems reliability. His current research focuses on the use of antimicrobials and the impact of antimicrobial stewardship programs at children's hospitals. He is co-founder of the Sharing Antimicrobial Reports for Pediatric Stewardship, otherwise known as SHARPS, collaborative for improving antimicrobial use in children that comprises more than 40 children's hospitals in the United States. And he'll be talking to us today about this experience in this collaborative project, so we're very lucky to have him today with us. Before we begin, I just want to remind our participants that we want to promote your engagement with our speaker, and a live question and answer session will follow the presentation. At any time, if you look to the bottom right-hand corner of your screen, there's a chat box there. So please, at any time, submit your questions to us, and Dr. Newland will be able to address those at the end of this presentation. So with that, I want to thank everyone for joining us and welcome Dr. Newland in his presentation today.
Good afternoon, good morning. Marnie, thank you very much for the kind introduction, and I really appreciate, again, the opportunity to speak with everyone about a real passion of mine, which is pediatric antimicrobial stewardship. As I was putting together this talk, I realized that things have just grown so much over the last 10 years I've been doing this, and so it was hard to it's gotten harder to condense it into 45 minutes to talk about all that's been done with antimicrobial stewardship in children, but I will try to give you a little taste of some stuff that we have done from primarily in the inpatient setting, including some work from the SHARPS collaborative that Marnie mentioned, as well as just touch briefly on outpatient antibiotic stewardship, as I think that's really the next, maybe not necessarily much the next frontier, but probably one of the most important areas we need to be addressing more of. So probably most of you have seen this target diagram. This is a publication that was produced or published by Sir Jim O'Neill from the United Kingdom. He's an economist, and he was commissioned by the NHS to determine what the economic impact would be in the future with antimicrobial resistant infections or pathogens if we didn't do anything and continued on the rate of use that we were doing. So in this target diagram, you can see in that light blue is the current number of deaths due to a number of different things, including tetanus, measles, cancer. And if you look at the current rate of death for antimicrobial resistant infections or pathogens, which are listed on the right, so we're only listing 6 pathogens, including HIV, tuberculosis, and malaria, those of which are more in the developing, low middle-income country aspects, and we're only including 3 common bacterial pathogens that we consider potential problems, but we know there's a lot more than this. But just taking these 6, currently we have 700,000 deaths, but if we continue on the rate we're going with our use of antimicrobials, by 2050, we'll have 10 million deaths. That will outnumber the number of deaths due to cancer, which is currently at 8.2 million. And this is annual. This isn't over the whole time. This is annual numbers. And the impact of that on the economic impact would be a $100 trillion loss, which is equivalent to the amount of money lost in the financial collapse of 2008, which ranges between 2.8 and I think 3.5% gross domestic product reduction. So that's the overview. I mean, all of you on this call or participating know this, and you're obviously vested in addressing our current needs of improving our antimicrobial use. And I could tell you a number of stories that I've had taking care of children who have died of bacterial-resistant infections, whether it was the 24-week infant who we can keep alive and they can grow to thrive. And I watched this baby develop a central line infection with Pseudomonas that we were able to treat initially with cefepime, that subsequently continued to develop resistance despite our best efforts, to where we were using colistin and the baby succumbed to that infection. And even if you go to the Infectious Disease Society of America website at idsociety.org, you can see a number of other stories of patients who we usually can keep alive with our amazing technologies and medicines, such as leukemics, transplant patients, those babies with one ventricle. And we can use antibiotics, but these stories will tell you that they've developed resistant infections and no longer can we keep them alive. So again, we're all on the same page, but I want to now just switch gears and talk about our antibiotic use in children. And probably the paper that I cite the most is a paper done by Jeff Gerber out of the Children's Hospital of Philadelphia, where he looked at a number of freestanding children's hospitals to see what was the percentage that received at least one antibiotic during their stay. And that was at 60%. And that, as you can see, that was 1 year, and is pretty comparable, I think, in other settings as well. I think the other important part of this study was the stark variability occurring among these like hospitals. So while these hospitals will try to say their patients were sicker than others, even when we controlled for those factors, the variability still ranged from 38% receiving at least one antibiotic to 72% receiving an antibiotic. And if we looked at the days of therapy, that varied from as low as 368 days of therapy per 1,000 patient days to as great as 600 days. And then we looked further about correlations, and we found that if you're receiving an antibiotic and your days of therapy were greater, then therefore your broad spectrum antibiotics were greater. So there were some aspects that thought, well, this definitely seems to be institution specific and maybe some cultural aspects to our antibiotic prescribing. And one might say, well, Jason, I'm not sure it's that big of an issue in pediatrics, right? Maybe you're not having the resistance problems. And I tried to tell you some stories a couple of minutes ago about that, but there's been a couple of papers done by LaTanya Logan and at the university, or excuse me, at Rush in Chicago. And she, in this figure, showed and evaluated the number of gram negatives that were producing an extended spectrum beta-lactamase. And this is taken from over 300 labs. And they were able to take the isolates and divide them into the ICU, which you can see is represented by the diamond, the inpatient isolates represented by the circle, and outpatient represented by triangle. And over time, and this is now, frankly, is an older paper, you can see the dramatic increase in the extended spectrum beta-lactamase producing gram negatives, to where 7% of your ICU isolates had some sort of extended spectrum beta-lactamase. Obviously, the things that make us most concerned will be those in the outpatient setting, because then you're talking differences in empiric therapy. If that rises to a level that now we're talking about quinolones all the time for potentially. Thankfully, we're not at that point. And I think more concerning is when we get to the Carbapenem-Resistant Enterobacteraceae, so those E. coli, Klebsiellas that are resistant to one might argue, one of our last line gram-negative agents, Meropenems and Imipenem and Doripenems of the world. And you can see even here, the inpatient ICU setting had a CRE in about 5% of the isolates. Again, concerning, and I wouldn't be surprised if not most, if not all of you have experienced trying to care for one of these patients with one of these resistant infections. But that's not the only aspect of this, and probably it's what we don't spend enough time discussing, is what's the impact of inappropriate or unnecessary antibiotic use on a more specific patient level basis that they could experience right then and there from that inappropriate use of antibiotic, and that's things like Clostridium difficile. And as you all know, Clostridium difficile can cause death, and we know based on CDC estimates that approximately 19,000 deaths, up to 30,000 deaths based on some other reports, are a result of the Clostridium difficile infection. In pediatrics specifically, we know it's increasing in hospitalized children, but it's more like, or I should say it's increasing more in the community-based setting. I've been telling this story recently, and is that a couple of months ago I was seeing an outpatient who received amoxicillin for what was thought to be a cellulitis. It didn't improve, so they switched to clindamycin. And then he developed this horrible diarrhea. His cellulitis, which subsequently was found to be actually a tinea corporis with a trichophyton species, but he had this awful 8 to 10 times a day stooling, lost 8 pounds, and he subsequently had C. diff. Now, he was a normal, healthy child, so he did well. But if you look at if you obtain C. diff in the hospital, your risk of mortality is at an odds ratio of 6.7. You're going to have an increased length of stay, increased hospital costs. These sorts of consequences of antibiotic use are real and have significant impact on children. That's not the only thing. Obviously, when you think of adverse events, we more likely think about vomiting, diarrhea, rash. There's an older paper now, I should say now, a more recent paper from JAMA that said antibiotics are the most common reason for emergency department-related adverse drug events in children. If you look at what's happened with the use of trimethoprim sulfamethoxazole, as that's increased in the era of methicillin-resistant Staph aureus, we've also seen our ADEs, our adverse drug events, tripled, and these are severe. These are things like Stevens-Johnson syndrome. These are like DRESS syndromes. And so if you look at a national basis, those have almost tripled in number. And people have felt that, and local institutions have seen dramatic increases in these adverse events. And these are probably the area we need to spend a little more time in understanding the amount of adverse drug events that are occurring with our inappropriate use. And that number has not been I think, well described or well investigated. All right, so I keep alluding to inappropriate antibiotic use. I haven't really talked about it. What is it? What number have they used? Many of you probably have heard the number quoted often, which is 30 to 50% of our antibiotic use is inappropriate. Well, what is it in children? Well, here are 3 papers between 2005 and 2012 that have looked at some specific either antibiotic, such as vancomycin and cefepime, or in a specific area. And you can see that in an older paper from Boston Children's, 35% of initial vancomycin courses were inappropriate. In a paper out of the Mayo Clinic in Minnesota, vancomycin was 11% was inappropriate, and cefepime 6%. These were more likely to be found in the PICU along with the surgical services, and really de-escalating and discontinuing was the most common reason to be inappropriate. And these were evaluated by 2 pediatric infectious disease physicians who are well-versed in the appropriate uses of these drugs. In a paper by Samir Patel when he was at Columbia, he looked at some criteria to antibiotic use in the NICU and found that about a quarter of all antibiotic use were inappropriate. He wasn't trying to tackle culture-negative sepsis. He was tackling things like treating colonization, so the 1 out of 2 blood culture for coagulase-negative staphylococcus, as well as using prolonged surgical prophylaxis. If you can remember anything from this presentation, remember the fact that we use surgical prophylaxis way, way too long, and we have a lot of room for improvement in that area. And I'll get into that a little bit more. All right, so again, I don't think among the group here I need to tell you what the definition of antimicrobial stewardship. I'm sure you're basically saying, yeah, I know that, Jason. So, optimal selection, dosage, and duration of antimicrobial treatment that results in the best clinical outcome for the treatment or prevention of infection with minimal toxicity to the patient and minimal impact on subsequent resistance. I mean, I think that's what we're all after. And I think in whatever drug we use, we want to do it right. And we want to have the best outcome. And that's an easy sell to people. So how can you do it, or how have people done it in pediatrics? Well, there's a number of different strategies, and maybe many of you know that. To me, it's the same sorts of strategies you use in the adult populations. You'll do it in pediatrics. Now, things might be a little different in some of the recommendations around that, but we can do it the same. I'm a big proponent of guidelines and pathways. I will show you a little data on a community-acquired pneumonia guideline. I'm including this link to the early onset sepsis calculator that can be used in late preterm infants 34 weeks or greater than 34 weeks. This is an amazing tool. I don't go into the slides as much, but you can see and get to this tool, and it can walk you through the information needed, as well as giving you guidance on whether antibiotics should be started, whether labs should be given or should be obtained. And this is based upon hundreds of thousands of neonates in this age range that are presenting, and people are considering whether antibiotics should be given for early onset sepsis. So I really, if you're trying to think of ways to improve antibiotic use in your NICUs or among your neonates, this is the place to go. A well-done study that we all should be using and implementing. So I'll also go in to a lot of literature around prospective audit with feedback. As you all know, this is where we allow the clinicians to order an antimicrobial, and then we review what the different, the different information we have on the patient and determine whether the dose, duration, the antibiotic itself is appropriate. And then finally, the prior approval approach, where you make people call you to get an antibiotic. Now, I had a question. I will address it now because I think it was back here. I'm going to go back. This slide, I think, is where the slide was. This was specific to pediatrics. All these studies were specific to pediatrics. This data here, if this is what the ratios were, this is also specific to pediatrics. So this was based on a large pediatric data set, administrative data. Great question. I'm sorry, I just noticed it, and I think I hopefully covered it.
Jason, this is Marnie. One of the other questions was also related to C. difficile ratios.
Oh, okay.
Yeah.
So the C. diff rates. I'm going to go to those slides just real quick. So this data here is based off of pediatrics. So the hospital onset data was from, again, a pediatric health information systems database. And the tenfold increase in the community onset, I think, was some large data sets from the outpatient setting. Yeah, the mortality odds ratio is very impressive. I completely agree. It really draws your attention. Now, you have to realize, sorry, that's what someone responded to. The part of the reason is that those kids in the hospital often have obviously a lot of underlying conditions that is driving some of that mortality risk, but they don't have the reserve that a normal healthy child will have. Great, thanks for those questions. I appreciate it. Thanks, Marnie, as well for the update.
Excellent, thank you.
Okay, so let's move into some of these strategies. So many of you likely are doing this work, but I'm going to tell you, I think guidelines can really work. And I think they can work because in order to develop a guideline, you have to engage the frontline prescribers. You have to get the stakeholders in the room. They have to buy in. And if you work with them in that buy-in phase, when you roll it out, most of the time they'll do the things that they believe in. So this is a paper we did. I arrived in Kansas City in 2006. I'm originally from Oklahoma, so you'll notice some twang at times when I speak. But I just arrived in Kansas City from Philadelphia. Now, mind you, if you're coming from Philadelphia to the Midwest, people look at you wondering what you're going to do or what you might try to do to them. And I knew that, being that I originally from Oklahoma. So we really treaded lightly on wanting to get to know people and try to think of ideas that could be easy. Well, pneumonia was one of those ideas. We talked with a number of people and said, hey, look, let's just switch from ceftriaxone to ampicillin. You don't need the broader coverage with ceftriaxone. Now, I will tell you, I also was angling for getting blood cultures on patients getting admitted because I wanted to be able to predict who was going to have a positive blood culture or not. That's probably not the right recommendation. And mind you, the clinicians realized that because it was more expert opinion based and they didn't change before and after the guideline. We also angled for decreasing the duration of therapy from 10 days to 5 to 7 days. They also didn't do that. I'm not going to show you that data. I'm just going to tell you those things they didn't do. But what they did do with continued work was they did change from ceftriaxone to ampicillin. And as you can see in this figure, on the y-axis is the percent of pneumonia cases per month that receiving either ampicillin in diamond or ceftriaxone in the circle or the dark line. And as you can see, as we implemented our stewardship program, which I'll talk about here in a second, and we implemented the guideline, we saw a dramatic change in what drug was being used for uncomplicated community-acquired pneumonia. And many of you are probably wondering, well, when you did that, did you see an increase in failures or more patients having complicated pneumonia, needing chest tubes, or more people needing to change antibiotics? And the answer to that was no. It was the same before and after. It was very low. And our guideline was implemented in July of 2008. The national guideline published by the Infectious Disease Society of America and for pediatric pneumonia developed by the Pediatric Infectious Diseases Society, they recommended ampicillin. They also recommended they need to make sure they were fully immunized. Now, we didn't say that, and we didn't see much difference. But again, that guideline came out in 2011, and we have been doing this, and again, we're excited that things weren't different. Now, what I can tell you is that by switching your therapy for uncomplicated pneumonia from ceftriaxone to ampicillin, when people send them home, they are way, 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 way more likely to send them home with amoxicillin. So you can see here before the guideline, we kind of had a mismox, that was a bad term. We can see that they were all used about the same, whether it's amoxicillin clavulanic acid, or ceftonir. Frankly, ceftonir being the worst drug for pneumonia. And so, in my opinion, we gave them better therapy. And we didn't have any increase in readmissions or increase in failures by doing this. So again, guidelines help. I will tell you, what also helps is following the data. I think you sometimes have to be patient. I currently have been working on eliminating the use of cefazolin or ANSEF for external ventricular drain prophylaxis. There was recently an IDSA guideline saying that practice should be no longer. I'm lucky to work with some great neurosurgeons who saw that and was willing to kind of talk with us and think about changing that practice. And over the last couple of weeks, after 6 months of kind of talking and developing a guideline, that's what they're doing. So it just reminds me that patience is key, working with your frontline stakeholders, trying to understand where they are coming from, and continuing to talk about it. And not necessarily, one might say push, but always being present, I believe, helps. All right, so let me switch gears now to what I consider a really important way of using prospective audit with feedback, or what I think is the best strategy. At least it's the best strategy for me. Now, with that, I think there's always the caveat with what resources you have to do this work. So I think if you have the resources to be able to go and talk with people as much as possible around antibiotic use in a prospective audit with feedback fashion, you will have great success, and you will garner a lot of support and understanding from folks. So in the best method in prospective audit with feedback, I believe, is a daily rounding or handshake stewardship technique, which has been penned by the group at the Children's Hospital of Colorado, Sarah Parker, Jason Child, and Amanda Hurst. If any of you are looking for a place to visit and watch how they do stewardship, inpatient pediatric stewardship, or frankly, even adult stewardship, you should go and see how they do it. It's really fascinating. And being that I watched them do it and then implemented that here at St. Louis Children's, I can tell you it works really well. So let's look at their work. So again, the way they set it up is they come in the morning, they review all new antibiotic starts on patients, I should say all new antimicrobial starts on patients, and then they also review any patients that's on an antibiotic or antimicrobial for greater than 72 hours. And you can see they have three different lines or trend lines. The first line on the left of each graph is kind of that pre-intervention period. The second line was kind of in the planning and in the initial implementation phase, and then after the last line, trend line, is really in their sustainable implementation phase. And you can see both for overall antibiotics and vancomycin use, there's a significant change in the slopes of these lines. And when you walk around with them, you notice a vibe or a culture that what they do at that hospital is they talk about antibiotics, and they expect and are looking forward to seeing the stewards coming by. Because the stewards don't just stop by to talk about the recommendations they have. They also stop by each of the medical services to ask them if they have questions and to give them any feedback. And so I believe that is a wonderful strategy, and one which we have used, and we get questions all the time from folks that aren't even involved with the patients we're reviewing for that day. Now, the program that I'm most familiar with, and one that I helped develop and now is led by Jennifer Goldman at the Children's Mercy Hospital in Kansas City, was again a prospective audit with feedback that was targeted toward a number, about 16 or 17 antibiotics. And this program has been in existence since March of 2008, and data has been collected since that time. And so as of this publication in 2015, there was over 14,000 patients that had been reviewed with antibiotics. And you can see the most common recommendations for this program was stop therapy, but things like modifying therapy and optimizing therapy were close, were right behind that. So there was a lot of initial change. I think importantly what this program has done and what Jen has taken on and done more of, I think, which is fabulous, is she's trying to understand where the disagreements are, where one could learn to improve the program. And not surprisingly, 22% disagreement was found, which is pretty the standard. I think if you look at other programs, you usually find about a 20% disagreement rate with your frontline clinicians in your recommendations. And this program, if you look in this, using the days of therapy per 1,000 patient days, and with Children's Mercy Hospital represented in the black line, and about another 25 children's hospitals represented in the gray line, when we looked at the most broad spectrum antibiotics, during the gray period, we saw an 18% average monthly decline. So obviously a significant reduction. But Jen has gone on further to say, let's look at the predictive probability of a recommendation occurring if we looked at it based upon a drug. So with the number of reviews and all the data we had, you could determine what factors were more likely to be seen with a recommendation. So interestingly, one of the most common drugs used in pediatrics was the one with the highest predictive probability to receive a recommendation. So over 20% of the time, you'd have a recommendation, and if you looked at just stop was recommended about 8% of the time. Now, many of you might be wondering, well, why is that? That might seem a little odd. Well, I will tell you that one of the areas we could do improvement around is RSV season, or the bronchiolitis season. There are a number of children or infants that get put on antibiotics for things like otitis media, or they'll see a right upper lobe atelectasis and be RSV positive, and they'll say, well, I'm afraid it's a superimposed pneumonia, despite no fever. I think there's a lot of work around here where we can see and improve our antibiotics, and that's where I think a lot of that is, and that's why there's a lot of recommendations there. We also looked at this by indication. And if you'll look again, I already set you up. Community-acquired pneumonia was a condition with the highest predictive probability of a recommendation. And you might say that's interesting in the fact that we have a pneumonia guideline, but it just shows you where you have a lot of work to do. Ear, nose, and throat was tracheitis in the intensive care unit. There's a lot of opportunities to change and to improve upon that prescribing. And again, I think surgical prophylaxis is something that we'll need to be talking about in the future, but I'll show you some other data here shortly. So I think what I like the most about this paper that Dr. Goldman did was around her evaluation of disagreement. So again, I said 22% disagreement. Not surprisingly, the most common disagreement occurred with linezolid in the carbapenems, so the broad-spectrum antibiotics. As you can imagine, the linezolid was primarily in the cystic fibrosis population, and we've seen Staph aureus resistant to linezolid. And again, I alluded to the most common indication that we need to work on, and that's the ears, nose, and throat, which is really tracheitis and pneumonia. But again, this is where I think the hospitalist general medical services are, we need to come together and kind of discuss the potential of where can we learn from one another and where can we improve our antibiotics. I think that this is an area we definitely can do that. So we also surveyed the clinicians, and I think that's always a fear, right, is that are people going to hate you? Are they going to want to throw you out? Because you're going to have some difficult conversations, which you should. You should be having difficult conversations. There should be some, tension at times around this work because you're really going in to talk to folks and telling them things they might not want to hear. But I think it's important and to see that, at least in our experiences, that people really appreciate the knowledge you bring. Recently, we were told by some residents here at St. Louis Children's Hospital that they felt like they were just floundering out there with antibiotics because they just knew they just started something. And they felt like, well, I just did what someone told me to do. And I think when you have a dedicated service to walking around and engaging in conversation to provide them some extra knowledge, because, look, our frontline clinicians are busy. They have a lot going on. To be able to teach a little extra on the antibiotics can be hard. And when you're the experts, it helps. Now, I think this survey demonstrates the belief that it's helpful. It also demonstrates the reality, which is we do take away autonomy. We do question their authority maybe in their use of antibiotics. Now, I always say I don't think we're threatening, and I hope we're not threatening, but that is a risk, and I think you can see why one might think that. So I think one of the other big issues is we have to be thinking about outcomes. What are the clinical outcomes? I can tell you that in the studies we've done, there's not been any increase in harm due to stopping antibiotics. This study here we did to try to say, well, we believe that the stewardship program makes outcomes better. So in this study, we again used that same time period I discussed in Dr. Goldman's paper, and we created 4 groups. We created the normal, what we would consider normal healthy medicine patient, and the medicine patient that had underlying conditions, such things as cerebral palsy, muscular dystrophy, cystic fibrosis. That's what's depicted in the CCC codes, and that's a number of different chronic care conditions. And we also did that for the surgical specialties. And then we looked at whether or not you agreed or disagreed, and we only looked at we didn't look at the ICUs, we did not look at the hem-onc population. And we said, let's look at the length of stay, depending on if you agreed with the recommendation or disagreed with the recommendation. And as you can see, the only place it looks like there might be a significant difference is in the chronic care condition medicine patients and potentially the normal surgery patients. But again, the numbers weren't super large, and this is in length of stay, but there is a suggestion maybe there's improvement. This again confirms what we've seen in a number of studies. It definitely doesn't cause harm doing this work. We also looked at readmissions, and unfortunately the numbers aren't enough, but again, the medicine patients looks like if you disagreed, you had more readmission, though not statistically significant, and we didn't see any readmissions in the other groups. I should tell you we did propensity score analysis, which reduced our numbers as we were trying to create groups that were equal. Another recent paper that we just published last week that I wanted to talk about was a metric that we've worked with Jeff Gerber, again from CHOP, and others at a spectrum score. So many of you, if not all of you, know about days of therapy. So as you know, days of therapy is a quantity-based metric. If you have a patient on 2 antibiotics for 5 days, that's 10 days of therapy. Now, let's say that's a child with a perforated appendicitis, and you're an institution that uses ceftriaxone plus metronidazole, versus a different institution that uses piperacillin tazobactam. I think this group would agree that ceftriaxone metronidazole is a much narrower drug combination than piperacillin tazobactam. So our intent was to create a score that kind of addressed how broad of agents you were using in your hospital. So in this paper, you'll see a big table that kind of defines or demonstrates how each antibiotic received their score. I've given you a couple of examples here. Amoxicillin had a score of 2 because it treated Enterococcus, and it can treat E. coli and some Klebsiella. Meropenem had a high score of 10. Tigecycline had the highest score of 13. And the way we used the metric was just to report upon the antibiotics received. So the denominator is antibiotic day, right? The denominator is not 1,000 patient days as we do with the days of therapy. So we see this as an additional metric, not a metric to supplant days of therapy, but one you could use in addition to. And here's an example figure from the paper. I will orient you to this. I should tell you, this data is obtained on pneumonia from the Children's Mercy Hospital experience that I showed you before where we did actual chart review. On the y-axis, on the left y-axis, you have the antibiotic spectrum index, or that score per antibiotic day. And on the y-axis to your right is the days of therapy per 1,000 patient days. And that's represented by the open. The ASI is represented by the dark circles. And so you can imagine the duration of therapy doesn't change when you're looking at pneumonia in a hospitalized patient. So it's not surprising that the open circles for days of therapy stayed pretty much the same per quarter. But as we changed from ceftriaxone to ampicillin, that did change. So this gives us some validity to that score, and I think we need more papers to look at this. And there are limitations, and we could talk for a long time on that, but again, I think this is another metric we're trying to look at and evaluate to see if it potentially could help us understanding antibiotic use and maybe help us improve our use as well. So the other thing I want to talk about real quick is about what children's hospitals are doing around the country. And this is a paper that's a little older now. It's about 4 years old, and we surveyed a bunch of the hospitals. And what we did in this paper is we defined what a formal stewardship program was. And what it meant to have a formal stewardship program was you had to monitor antibiotic use. But more importantly is you had to have financial resources being given. So you had to have some money paid to a pharmacist and or physician and or data analyst. Now, when we asked questions of these hospitals what kind of approaches they did, you can see that their main approach wasn't much different, right? They were the same, whether they were doing prospective audit and feedback alone or both. Part of this is just that people are doing this work without having any financial benefit or financial support. What we did see is that if you had financial support, you were way more likely, but you were more likely to monitor outcomes, whether they were antibiotic use specifically being the most significant as well as. So we've really pushed among our hospitals to get financial resources because you're able to do more and do a better job. In this paper, we also looked and compared those hospitals with the stewardship program versus those without. In this figure, the black line represents the use of those with the stewardship program. The light gray line represents that of those without a program. The gray shade is where you had a significant, or where you had a difference between those with a formal program and those without. So this data would suggest that, having a formal program leads to greater improvement. The other thing I want you to look at is antibiotic use is decreasing anyway since January of 2007. And this is really the impetus that led us to develop the collaborative. We noticed people were already working on this. This led us to say we wanted to understand the hospitals more. We also saw it as an opportunity to work together. I think we have to collaborate, especially in pediatrics, and we helping or learning from one another, sharing in each other's struggles as well as successes, I think only makes us all better. So we developed the SHARPS Collaborative, which stands for Sharing Antimicrobial Reports for Pediatric Stewardship, as Marnie mentioned earlier. The reports are generated out of the Pediatric Health Information Systems database. We are now over 45 children's hospitals. That's what I'm saying right now. And we usually gain a few hospitals. And the hospitals do not necessarily now have to be hospitals that deliver data to the FIS data set. Because, we look at this as a sharing learning collaborative. We have monthly webinars. They're typically the third Thursday of every month. We often have other hospitals presenting their work. We have a very active listserv that is managed by a coordinator that I have that works with me here at WashU. And she receives questions and sends out questions and answers 3 days a week. It's very active. I've learned a ton from that. It's a great group. We've also tried to have a social media presence. We have a lot to learn, and I think all the great work CIDRAP's doing is such a wonderful example and a great site for all of us to get even more information. What I want to show you now is just, here's the hospital. So you can see it spans across the country. We've added a few more hospitals over time. To be a part of the group, it costs $0. We just ask for engagement and participation and to really share what you're doing in your learnings. And I do realize I left off the Upper Peninsula. I apologize to any Upper Peninsula folks. I have heard that. The other thing I want to show you is what's happened with our FTEs. So this wonderful, some of you might not be thinking wonderful figure, looks at the FTEs being allocated to each group here: blue pharmacist, red physician, green and analyst. This data represents data from 2013, I think, to the end of 2015. You can see we have 36 hospitals, of which 6 didn't have any FTEs. The median for the pharmacist was about 0.5, and the median for the physicians, I think, was around 0.2, and only 2 hospitals had a data analyst. When we repeated the survey in the fall of 2016, so about a year ago, we've had a dramatic change. I think we're still at around 4 or 5 hospitals. We've also added a lot more hospitals, and now the median for a pharmacist is as much as 0.9, with one hospital having 3 FTEs, a couple of hospitals having 2 FTEs. You can now see about 15 or 16 hospitals have data analysts. The median FTE for a physician is 0.3. So our hospitals are giving the resources necessary, or trying to do that, so that we can continue to improve our antibiotic use. And I can tell you that the Children's Hospital of Colorado has a recent paper that demonstrated they have an up to $2 million savings since their stewardship program has been in place, which has allowed them to add on more FTEs, including more substantial efforts for even their physician, who has a 0.8 FTE now, because of the great work, and also because they take the time to show that work. I think to kind of finish up here over the next 5 minutes, one of the things I'm just so excited about and just so blessed to have this group of hospitals to work with is that about 30 of the hospitals came together to do point prevalence surveys. So take it one day and look at all the antibiotic use in your hospital. And we've done that quarterly. And you can see we actually have done 6 quarters. The first quarter, I should say quarter 2 of 2016, the blue far left bar was the quarter where only 2 hospitals, but after that it's been about 30 hospitals each quarter. And in this figure, you see 2 things. One, you see everybody, which is the peer hospitals, and you can see the prevalence. So of all the patients in the hospital, what percentage are receiving antibiotic? And we've been pretty consistent between 36 and 41%. At St. Louis Children's Hospital, we've been between 31 and 35%. Now, this data is similar to what has been shown in some other point prevalence surveys for children's hospitals as well. So again, we use a lot of patients are receiving antibiotics. The thing we try to tackle was inappropriateness. We had specific questions that the stewards completed to determine the inappropriate rate for all the antibiotics, so just antibacterials being used. And you can see per antibiotic, this isn't per patient, so per antibiotic we're at about 15% inappropriateness rate. If we look at by patient, the number goes to about 20%, because as you can imagine, some of these patients are receiving more than one antibiotic. For our own hospital, at St. Louis Children's, we have been as high as 28%. This is quarter 3 of 2016. This is right as we were starting our prospective audit with feedback Handshake stewardship, antimicrobial stewardship program, and we've seen a decrease. Now, this could be just based upon, the different time of year, and so we'll see if this last quarter 3 of 2017, we've done the data, but we just haven't have it analyzed. We'll see if that has changed any. So now I want to just show you what the most common antibiotics are being used in our hospitals. Trimethoprim sulfamethoxazole is number 1. And of that use, 4.9% has been deemed inappropriate. Vancomycin has the highest inappropriate rate of our common use antibiotics at 19%. And as you can see, these are our most common antibiotics really, for the most part, are broad spectrum if you think of ceftriaxone, vanco, and piperacillin, tazobactam. So again, a lot of room for potential improvement. The cefazolin inappropriate use of 22% is inappropriate surgical prophylaxis, and that's based on allowing 24 hours or less to be appropriate. So I would argue with the recent CDC recommendation saying we should only be using 1 dose for clean and clean contaminated procedures, this number is much higher. If we look at indications, not surprising with Bactrim being your number 1 drug, prophylaxis for medical problems comes up very high, and also not surprising being where pediatrics, we see a lot of lower respiratory tract infections. And again, you can see the inappropriateness rate, and again, prophylaxis for surgical disease is the greatest. Our reasons, not the most common: bug-drug mismatch, surgical prophylaxis, and treatment not indicated. I will tell you that we had 3 main inappropriateness that we were looking at, and that was bug-drug mismatch, surgical prophylaxis for 24 hours, unnecessary duplicate therapies, and IV to PO. So 4 main things. And then we had another category. And then with the others, we changed that to all of these aspects where we added in these different categories. Determining inappropriateness, again, is based upon what the stewards at the hospital said. So if you wanted to argue with me that there's some variability there, I would agree with you. There's probably variability in the inappropriateness rates at the different hospitals. But it is a number that I think has been pretty consistent, and I think is a fair number that I think we have room for improvement for sure. Lastly, with this work, is we wanted to try to determine where our hospitals were missing opportunities. So these bars represent percent of inappropriate antibiotics. And on the axes on the left or the y-axis, you have, did your stewardship program review it greater than 5 days ago, review it within the past 5 days, or will review versus those who just don't do the stewardship program at all, or they don't routinely review the antibiotic. And you can see that among those programs, 40% of our inappropriate use, the program doesn't even see it. So these are areas you can think, wow, maybe I should be changing how I do the antibiotics or how I review these patients, or maybe I need to think of other strategies. Okay, I got 10 minutes, really quick. Outpatient antibiotic use. We use it all the time. 49 million prescriptions, 21% of visits, 70% for respiratory conditions. And frankly, we use drugs we shouldn't use, such as azithromycin for these conditions. There's no really utility for azithromycin. Maybe if you have a true penicillin allergy, maybe. So I think there's a lot of room for improvement. In this figure, what they've basically shown is there's an excess of 11 million prescriptions in our outpatient setting. This is a great paper I would definitely suggest you look at on regards to outpatient use. And the best study looking at stewardship from a pediatric basis, or at least a stewardship intervention, is done by Jeff Gerber. As you can see, he's done a lot of great work both in inpatient and outpatient, where he basically did education for a number of pediatric practices, and then some of the practices received basically a antibiotic report, where he showed each prescriber's antibiotic use or their broad spectrum antibiotic use versus everybody else. And so if you see, those who received their report card in orange had a significant reduction in broad spectrum antibiotic use. And in this case, this was a standardized ratio, and this was the same for sinusitis or all those things. The problem was, when the funding went away, the intervention effect went away. So there's a lot of work that's currently being done about behavioral techniques, communication techniques, and so I think that's what you should be looking for in the future. Okay, so lastly, the future. Well, the future now for inpatients is the regulations. Many of you probably have already had Joint Commission surveys. They're coming. It's been effective as of January 1 of 2017. I have to do a mock survey next week. I can't wait to see what they're going to ask me. And in Missouri, we actually have a state law that now requires all facilities to have stewardship programs as well as deliver data to the CDC's antibiotic use module, which I believe is really the next step, is that we have a risk-adjusted metric, the standardized antimicrobial administration ratio, that is based upon a quantity-based metric, days of therapy, but it does provide facilities or observed to expected ratio. I think as pediatric hospitals, we should be working toward delivering our data here, partially because we need to be on the front line about knowing what everyone's doing, as well as to make sure we use this data appropriately. So I think hopefully you see, and you probably know, that we use antimicrobials often and frequently in both inpatient and outpatient settings. There are definitely room for improvement. There are definite strategies that can be used and can be successful, but we're still in need of a lot of data, clinical outcome data, better metrics, better strategies. I think now in the world of implementation science, we should be thinking about how do we de-implement things that have become just habit. So surgical prophylaxis is one. I sent an email to a urologist on Monday about stopping ampicillin and gentamicin for a bladder exstrophy case, and the response to me was that the only dehiscence they've ever had was when they used it for 48 hours, and that's 1 in 20 years. And so we have a lot of, whether we can say, learning to do on how to do this better. And so with that, I'm willing to take some questions. I see the first question is, how do you go about joining the Sharps Collaborative? Well, email me. I'm going to put it here in the chat box. Email me. We will get you set up. It's pretty easy to do. You can join in on the webinars. We just ask you to complete an intake survey. The reason for the intake survey is so that we can understand what your program looks like, and then we'll get you set up with everything. So, Rob, I look forward to hearing from you.
That's terrific, Jason. Thank you. Yes, I think it's important that people understand how to join the collaborative. And another question that came in, and I think this is the data where you were talking about total FTEs as they are continuing to grow that are devoted to antimicrobial stewardship. Do you have data that looks at the total FTE per hospital bed? Because I assume that obviously the higher amount of FTE correlates with the bed
Yes.
hospital bed number?
It doesn't actually. So in a paper we published recently or in the past year that I didn't show, we did look and see if there was a correlation with number of beds and FTE, and it did not. Now, we also are currently trying to understand if FTE amount correlates with inappropriateness or your rate of inappropriateness, because we can link that with that point prevalence survey. And we haven't done that analysis yet, but what's interesting about the inappropriateness data is it is currently doesn't look like it's linked with whether or not you do prospective audit with feedback or not. So I find that an intriguing thing, though we also don't know the intensity that each program is doing. And so how do you want to define intensity? Might be, as you suggest, the number of drugs you're monitoring, but intensity could be the way you do it. So are you walking around every day? How many hours do you spend? And I don't think we quite know that yet. I will tell you that the data suggests that the strategies associated with the least amount of inappropriate use is having defined duration, so making sure you have stop dates in. That's one. And using rapid diagnostics. I get the stop dates. That makes sense to me. If you can get people to do that, they're more likely they're going to get things stopped you didn't realize. I'm not sure. I think I understand why rapid diagnostics, but I'd like to understand that a little bit more. Yeah, so next question. How does the stewardship team approach documentation and handshake stewardship? Man, Shannon, this is a great question. It's a really important thing to kind of think about. I think it's an important thing for all programs to decide how you're going to do it. So at the Children's Hospital in Colorado, or Colorado Children's, they have a documentation system within Epic. It is not an official, quote-unquote, part of the medical record. However, it is discoverable. Look, it's not going to print with the chart for a patient, but if someone really wanted to discover it, it's considered discoverable. But that gets into the next question is, do you do notes or not? In Kansas City, we did notes on only the people that agreed. Here at St. Louis Children's, we haven't done notes yet. I've gone back and forth. I think we probably will do notes once we get Epic. We're going to Epic Live in June. The aspect around notes for me has always been I don't want to alienate my frontline prescribers. I use the philosophy that it's all about communication and collaboration. I don't want them to feel like I'm boxing them in or throwing them under a bus. I do think that there has to be a happy medium to do this. If you talk with legal experts, and there's a lawyer out of the University of Pennsylvania who works with Keith Hamilton at the University of Pennsylvania, who suggests that the more information we have in the charts, the better. And working with legal folks in my patient safety days, that makes sense, right? The more you have out there, the more transparent you are, often the better. I'm just not sure as if it's worth it. But I think that there's still a lot to learn there. So thank you for that question. I think it's a really important topic, and I think something we all struggle with.
You mentioned we have about a minute left. So final question here related to how do you engage with your clinical microbiology lab and use your diagnostics? Thanks, Marty. That's so important. So, and I didn't get into that very much, but in this day and age of rapid diagnostics, I mean, there's a plethora of papers that demonstrate if you implement a rapid diagnostic without the help of stewardship or some kind of algorithmic approach that makes sure that the microbiology is engaged with someone that's going to affect the change, it's a waste of money, and it's a waste of time and energy. So the engagement has to be up front. You should be first name basis with your microbiologist. I'm very lucky. I have Carrie Ann Burnham and Neil Anderson and Melanie, and I talk to them frequently, and I can call them up and get insight. And we're working always on different ways of doing new techniques.
I think biomarkers like procalcitonin, I think that's another one where our stewardship programs have to be right in with our, whether that's microbiology or your clinical lab in general, on working together on how to use that appropriately. Because you could use procalcitonin just like it happens with CRP, and nobody knows what to do with it. They see the number and they're like, that's great. What do I do now? So I think that's the stuff us stewards have to be working closely with those folks to do better.
Terrific. Well, thank you, Dr. Newland, for a lot of insights and a lot of information, and I really appreciate you describing your personal experiences, and then importantly sharing the SHARPS program with those participants on the webinar today that would like to join. Sounds like it can be very valuable and really a good community for pediatric infectious diseases stewardship programs. So with that, I just want to thank our participants for joining us today and remind everyone that the webinar has been recorded and will be available within the next couple of days on our CIDRAP ASP website. And I have also sent Dr. Newland's email to everyone, all the participants. So I assume he is open to you contacting him for more discussions. Thank you, Dr. Newland.
You're welcome. Thank you. I really appreciate it.